This is a lecture on Chapter 11, Diseases and Conditions of the Urinary System. This is part 1 of the lecture. And as far as Chapter 11, we are going to cover all of the diagnoses in this chapter. If you are not familiar with the anatomy of the system, you should definitely review maybe in your medical terminology book or an anatomy book, and also your textbook. The Essentials of Human Diseases and Conditions does a really good job at the beginning of the chapter doing a basic review of the anatomy. If you'll review this, you'll have a better understanding of the structures that I'm going to be referring to. The first thing that I want to do is talk about a few diagnostic tests, and those diagnostic tests, or a couple of them anyway, are described on page 520 to 521. That's table 11.1. Starting with the urinalysis. When a urinalysis is performed, there's a number of different sub-tests that can be done as a part of this urinalysis. When the urinalysis is performed, the technicians are looking for the color and clarity of the urine sample, the chemical nature, like the pH of the urine sample, the specific gravity. And in your textbook, they do a good job of telling what is normal, like the normal specific gravity being between 1.003 and 1.030, and telling you a little bit about this reflecting the amount of waste and minerals and solids in the urine. And then they tell you a little bit about the abnormal, that the higher specific gravity causes precipitation and solutes, the lower specific gravity, polyuria, which is excessive urination. Under constituent compounds, there's a listing of protein, which the normal is no protein. The abnormal is called albuminuria. Albumin is a certain type of protein that will show up in the urine when a person has certain forms of kidney damage. Glucose, no glucose is to be present. If it's abnormal, it's called glycosuria, and it indicates that there's sugar in the urine that could be a sign of diabetes mellitus. It is a sign of diabetes mellitus, and a few other things. Ketone bodies, when a person has ketone bodies showing up in the urine, again a sign of diabetes, and if it's a high level of ketonuria, it could be a sign of diabetic acidosis. So there's a good listing there of what's normal, abnormal, and the pathology that the abnormal may indicate. Also described in table, this is 11.2, the blood urea nitrogen test is BUN. And you see on the first column of that table 11.2, serum creatinine and BUN, designed to evaluate capacity to eliminate end products of protein metabolism. The creatinine and BUN are very good indicators of normal kidney function, and if they're elevated, then it's a good indication of insufficiency of the kidneys. Cystoscopy, the scopes are those instruments used to perform a visual examination. This process, the cystoscopy, allows visual examination of the inside of the urinary tract, inside of the bladder. It's used to do examinations and also to remove biopsy specimens. Even can be used to remove stones or tumors. IVP, intravenous pyelogram, is a fairly common imaging procedure, a type of X-ray, in which contrast material is injected to a vein and travels to the kidneys, and on the film, on the X-ray film, the kidneys can be viewed as they filter the urine. Shows the contrast material filling the kidneys, the ureters, the bladder, and the urethra. first condition to talk about is the acute glomerulonephritis. And let me just go back just a couple pages in the chapter to look at the normal structure of the kidney. And in the normal structure of the kidney, the lower picture on page 517 is the nephron, made up of glomerulus. The glomerulus, the normal function of the glomeruli, more than one, there's millions of them in each kidney. The normal function of the glomeruli is essential to the normal functioning of the kidneys. This is where the filtration of the blood takes place, where the waste products should leave the bloodstream. When a person has acute glomerulonephritis, it's acute, it's very severe, it's got a very sudden onset, and it's usually short-lived. The acute glomerulonephritis is also called Bright's disease, and there's a form of acute glomerulonephritis in which the condition, this inflammation of the glomeruli, follows an infection with the group A beta hemolytic streptococcus. It's an antigen-antibody reaction that causes this acute damage to the glomeruli. Signs and symptoms: chills, fever, loss of appetite, malaise, edema. Edema is really common in any type of kidney disease because the kidneys are responsible for filtering the blood, and if there's a problem with the glomeruli, that protein that I mentioned a few minutes ago, albumin, escapes out of the bloodstream, and albumin is the actual protein that helps the water stay in the bloodstream. So if this albumin, the protein, is escaping out of the bloodstream and going through the kidneys and the tubule and the renal tubules and being lost in the urine, when the albumin's lost in the urine, you no longer have it in the bloodstream to help keep the fluid in the bloodstream. Therefore, it seeps out in the tissues and forms this edema. So especially edema of face and ankles. In any form of kidney disease, it's likely that the person's blood pressure is going to rise, that they'll develop hypertension. Because of the hypertension, the person may have headaches and visual disturbances when they have the acute glomerulonephritis. Urinalysis shows that albumin, that protein showing up in the urine, and often hematuria. The hematuria can be just a microscopic amount, or it can be rather significant. Again, this is a condition that most often occurs in children, and it usually follows that streptococcal infection by 1 to 2 weeks. It's also called a post-streptococcal glomerulonephritis. The person will have back pain, back pain in the area of the kidneys, because the kidney tissues actually swell with glomerulonephritis. Treatment: there's really no specific treatment for the post-streptococcal type other than antibiotics. Diuretics will help with the edema to get some of the fluid off the body. Sodium intake will be restricted, again, to help with the edema. Most cases resolve spontaneously. Now, the chronic glomerulonephritis, on the other hand, a chronic condition has a slow progressive development and slow progression, stays around for a long period of time. The chronic glomerulonephritis is usually a non-infectious disease, where the acute glomerulonephritis may very well be infectious because of strep infection. The chronic, a lot of different causes for the chronic glomerulonephritis. As far as triggers, the person may have some multi-system disorder like systemic lupus erythematosus, Chronic glomerulonephritis, again, there's inflammation of the glomeruli, and there's kind of an enlarged picture of the glomerulus on your screen right now. And there's inflammation. Again, there's millions of glomeruli in each kidney. And in chronic glomerulonephritis, many of those glomeruli have become inflamed. And again, it's progressive, so many more will become inflamed because the condition that causes the chronic glomerulonephritis is usually a chronic condition also, like lupus. Asymptomatic early in the process, and then hypertension. Chronic kidney disease and hypertension they just go hand in hand. The high blood pressure with any type of chronic kidney disease like glomerulonephritis. Hematuria will develop. Again, it may be microscopic or it may be more obvious. The proteinuria, the albumin escapes into the urine, and oliguria, the person will begin to not produce enough urine. Edema, again, that goes along with any kind of kidney disease. Later in the stages of chronic glomerulonephritis, there'll be some degree of renal failure. And again, the severe hypertension, the azotemia, the buildup of the nitrogenous waste in the bloodstream, fatigue, nausea, vomiting, pruritus, and dyspnea all go along with the chronic glomerulonephritis. As far as lab values, the specific gravity of the urine is usually low with chronic glomerulonephritis, and the BUN will increase as the renal insufficiency increases. The person with chronic glomerulonephritis may have bouts of remission where they appear to be okay without signs and symptoms, and then there'll be an exacerbation, which is a worsening of all the signs and symptoms. Treatment, they need to control the high blood pressure, antihypertensive medications, diuretics for the edema, and then focus on prevention of renal failure, and then treatment of renal failure when it does occur. Chronic glomerulonephritis may lead to renal atrophy, a kind of shrinking away of the kidneys, and again the kidney failure with uremia. One of the treatments for renal failure, whether the renal failure is due to chronic glomerulonephritis or other conditions, dialysis. Dialysis is one of the treatments. There's two different main forms. There's hemodialysis, and then there's peritoneal dialysis. In hemodialysis, the word parts there, hemo's blood, lysis is separation, dia is complete separation of blood. It's actually a separation of the blood from the waste products using an artificial kidney machine that receives the waste-filled blood from the patient's bloodstream, filters it, returns it to the cleansed body. I have a picture here on this next screen of a patient being on a dialysis machine. They have to have some type of catheter inserted in a vessel, and the blood comes from the person. The blood's pumped into the dialysis machines. The blood's filtered there. It's cleansed, so to say, and then the cleansed blood will be pumped back into the person's system. Purified blood is pumped from the dialyzer into the arteriovenous fistula that's been created in the person for the purpose of the dialysis. All right, now I want to back up one screen and talk about the peritoneal dialysis. Using a catheter, a special solution is introduced into the peritoneum, the abdominal cavity, and that solution actually filters the waste, and then the contaminated solution is then drained and replaced with fresh solution. And I've got a diagram, somewhat a diagram of that also, where the catheter is inserted into the peritoneum. The fluid fills the peritoneum. The fluid somewhat absorbs the waste products, and then the fluid is drained off of the body. That's peritoneal dialysis. And there's a good description in the enrichment section of your textbook. Also, there's a good picture of performing the dialysis in your textbook also, a good illustration, figure 11.6. Okay, now we want to look at nephrotic syndrome, also called the protein-losing kidney, and the protein that's being lost there is albumin that I've mentioned before. This is also referred to as nephrosis. There's several symptoms that go along with a person having nephrotic syndrome, and several etiologies there. The person may develop this nephrotic syndrome because of a bout with glomerulonephritis. It may result from poisons or medications that a person's taken into their body. Even pregnancy may cause nephrotic syndrome, and kidney transplants. In box 11.1 in your chapter, they show several of the known nephrotoxic agents that are damaging to the kidney, like lead and arsenic. Certain pesticides, certain antibiotics are very damaging to the kidneys, and other compounds. You should look over that list there, that box. The person may also develop nephrotic syndrome as a complication of having diabetes mellitus. Certain infections, certain allergic reactions may also cause nephrotic syndrome. Signs and symptoms: there's going to be some edema there, puffiness around the eyes, swollen ankles, depression, anorexia, just really not feeling like eating, paleness, weight gain, proteinuria again. And when the person has the proteinuria, where they're losing albumin in the urine, they'll also have hypoalbuminemia because they don't have that albumin staying in the bloodstream. So they have low levels of the albumin in the blood when they have the albumin escaping in the urine as proteinuria. The treatment of the nephrotic syndrome is focused on the underlying cause of the nephrotic syndrome. If the nephrotic syndrome is not controlled, it will eventually progress to end-stage renal disease, where the patient has to either have a kidney transplant or be on chronic dialysis. Okay, now acute renal failure, abbreviated ARF, sudden and severe reduction in renal function. Common clinical emergency because nitrogenous waste products begin to accumulate in the blood quickly, thereby causing an acute uremic episode. Something causes a decreased blood flow to the kidneys. It could be an obstruction. It could be trauma. It could be one of those nephrotoxic agents that I mentioned a few minutes ago. It develops suddenly, but it usually is successfully treated, depending again on the cause. Signs and symptoms: oliguria, they're not producing much urine. They'll also have GI disturbances, headache, drowsiness, and this ammonia breath odor because of the buildup of nitrogenous waste. Muscle weaknesses, bradycardia, slow heart rate, and alterations in level of consciousness because they're being poisoned by the nitrogenous waste that should be filtered out of the bloodstream. You hope that your kidneys are working to take the nitrogenous waste out of your body. And if not, the nitrogenous waste are going to build up and cause a poisoning there from the acute renal failure. Treatment's focused on whatever's causing the failure. Oral intake will be restricted to allow the kidneys to rest. And nephrons can regenerate when they're damaged, if they have the opportunity to rest. Very careful nutritional support, and the temporary dialysis may also be necessary. Your textbook shows a very good picture in figure 11.8 of some of the causes of acute renal failure, such as those nephrotoxins that I mentioned, ischemia, which would be something holding back the blood supply to the kidney, or pyelonephritis, inflammation and infection of the kidney. Okay, this is chronic renal failure. Develops slowly, usually with a poor prognosis. Chronic, it's there for a long period of time. Signs and symptoms include weakness, lethargy, hypertension. When someone has chronic kidney failure, they generally have high blood pressure also. Kidney disease will cause hypertension, and hypertension will cause kidney disease. With chronic renal failure, there's going to be edema present, dyspnea, and other signs and symptoms due to the accumulation of those nitrogenous poisons in the system. Because of those poisons, those toxins, the nitrogenous waste, they'll develop ulceration of the gastrointestinal mucosa, and then have problems also with their central nervous system, decreased mental ability, dim vision, convulsions, coma. There's a number of different areas in the body. It's a systemic problem. When the kidneys are not able to perform the function of filtering the waste and taking the waste out of the body in the form of the urine, a number of different areas that will be affected, including the heart being affected by the rhythm not being what it should be. They develop arrhythmias. Some of the causes, the chronic glomerulonephritis will result in chronic kidney failure, pyelonephritis, polycystic kidneys, hypertension will cause chronic renal failure, diabetic nephropathy results in chronic renal failure. The chronic renal failure can be diagnosed or substantiated by an elevated BUN, elevated serum creatinine, elevated potassium levels go along with the chronic renal failure. Along with decreased hemoglobin and hematocrit, the person will become anemic because their kidneys are not functioning properly. Urinalysis is grossly abnormal. X-ray scans and sonograms of the kidney will be used to evaluate the extent of the renal failure. In later stages, the person's going to have dialysis, and maybe even kidney transplant will be necessary. They'll need antihypertensive drugs because chronic renal failure and hypertension just go hand in hand. Antiemetics because of the gastrointestinal effects of the condition. And now pyelonephritis. The renal pelvis is referred to as far as medical term as pyelo. So pyelonephritis is inflammation of the renal pelvis, and the inflammation is most often caused by infection, caused by some infectious agent. Now, calculi, having stones in the kidney, can also cause pyelonephritis. Just the condition of being pregnant may result in pyelonephritis, but more often the patient has pyelonephritis because of an infectious agent. Figure 11.9 in your book does a good job to demonstrate some of the causes of the infections. Anytime that a person is immobile, they're not moving as much as they should, they get a little dehydrated, their urine becomes static, it's not moving, it's not being produced, it's not moving out of the body at a good rate, it's more likely that infection will build up there. Signs and symptoms are signs of a systemic infection with chills and high fever, nausea, vomiting, lumbar pain, dysuria, the difficulty urination and pain, urinary frequency, going too often, and urgency. May even have some hematuria, which is blood in the urine, or pyuria, which is pus showing up in the urine. And the person may also have a bit of confusion if the pyelonephritis becomes serious enough. If pyogenic cause, which means if the cause is bacteria, pyo is pus, bacteria cause pus formation. So if it's a pyogenic cause, the most likely organisms that cause pyelonephritis would be the E. coli, Streptococcus, Staphylococcus, but there are certainly other microorganisms that can result in pyelonephritis. the test done to diagnose the organism causing the pyelonephritis is a urine culture and sensitivity study. The urine culture is performed to determine what organism is causing the inflammation, and the sensitivity part of it is performed to determine which antibiotics the organisms are sensitive to, or which antibiotics will be useful in destroying those organisms. Culture and sensitivity studies. So the appropriate antibiotics will be used in treatment. The patient's advised to increase fluid intake, especially intake of water, and bed rest is so important there. The prompt treatment usually has a good prognosis, but if the patient is allowed to go too long with damaging pyelonephritis, they may end up with some serious bacteremia and chronic or even permanent kidney damage. Okay, now hydronephrosis. Hydronephrosis, it's the actually buildup of pressure on the renal pelvis because the urine is not flowing properly away from the kidney. Abnormal dilation of the renal pelvis caused by pressure from urine that cannot flow past an obstruction. Something is causing an obstruction so the urine doesn't flow. In this picture, we're showing a diagram with a renal calculus right here. The obstruction here is a stone in the ureter. In a normal functioning kidney, the urine is formed, and then the urine will move from the kidney down the ureter into the bladder. And then it's held there until it's time to release the urine through the urethra to the outside of the body. When a person has an obstruction, like a kidney stone, the urine that should be moving out of the body is building up, causing this hydronephrosis. Hydros, fluid, abnormal condition of the kidney. The fluid builds up on the kidney and causes an enlargement of the kidney, a dilation of the renal pelvis. Now, the obstruction could also be something from the outside. Like I once knew someone who had a tumor on the outside of their kidney. It was actually out here in the peritoneal cavity, and the tumor formed over the ureter and caused such pressure on the ureter that it stopped the flow of urine out of the kidney. So the person developed hydronephrosis. And it really may not be real obvious when the person develops hydronephrosis if the other kidney is normal and functioning normal. In fact, in this patient who had the cancerous tumor that put the pressure on the ureter, they had the hydronephrosis of the kidney for so long that the kidney eventually stopped functioning. Because the person had a normally functioning kidney, they didn't even realize that the other kidney had stopped functioning. So it may result from urinary calculi, from a tumor. It may result from inflammation caused by infection, and enlarged prostate. In the male, the prostate gland actually wraps around the urethra. And when the prostate gland becomes enlarged, it may cause the urethra to have blockage so that the urine doesn't flow like it should out of the bladder and through the urethra. And that will cause the buildup of fluid in at least one of those ureters. So the symptoms of hydronephrosis may go undetected. They may be very vague symptoms, and destruction of the kidney may take place before the person realizes what type problem they have. I need to back up on that last slide, make sure that I left it up there long enough for you to see my statement there that the hydronephrosis may result from urinary calculi, tumor, inflammation, enlarged prostate, or a congenital defect, or any other obstruction of the renal pelvis. And that's all documented in your textbook under etiology. So symptoms are not always clear. If infection's present, then the person's going to have the signs and symptoms of infection, like fever and chills. They may even have pyuria, the pus development, or the pus showing up in the urine, and may even have some degree of hematuria, but it may be microscopic that the patient doesn't notice it, and it would only be detected on urinalysis. Treatment for the hydronephrosis is going to be focused on the cause, and of course any antibiotics for the resulting infections. This is meant to show that a person that has a kidney problem may actually feel like they have a rhinoceros horn stuck in their back, especially with kidney stones. There's such pressure in the back, so the patient may go to the doctor and just express just what pain they're having in the lower back. It may be directed towards either the right side or left side, depending on what side the stone is located on, if indeed it's a stone causing the problem. Medical term for stone is calculus. The word part for stone is lith. Lith is stone. So if you're looking at nephrolithiasis, it's an abnormal condition of stones in the kidney, also referred to as kidney stones or renal calculi. Now, we say they may be asymptomatic. If they're asymptomatic, it's because they're really small and they haven't caused any type of obstruction at the time. When they start moving, when the kidney stones start moving or causing obstruction, and if they're very large, then they are going to cause intense pain. The pain's usually referred to as pain in the flank area, the lower back towards one side or another. They may have such severe pain that they develop nausea and vomiting, frequent nausea and vomiting, urinary urgency, hematuria, blood in the urine again, fever, chills, and abdominal distension due to those kidney stones. The stone may block the flow of urine that I mentioned a few minutes ago, resulting in hydronephrosis. This picture here is showing an actual kidney stone. They form when there's excessive uric acid or calcium in the blood. There's several risk factors. I have 3 different friends right now that have actually had kidney stones in the last 3 weeks. All of them are pretty sedentary as far as not moving around a lot, so certainly we know that immobilization, not moving much, not much exercise contributes to the development of stones. Prolonged dehydration, these people probably don't drink enough water, and they've each been told by their physicians that drinking dark colored fluids like tea and Cokes and other dark sodas will increase the risk factors for the kidney stone development. Certain other diets high in vitamin C, will cause that increase in the likelihood of developing stones. Also, if a person has a problem with their parathyroid gland and produce too much parathyroid hormone, if they have hyperparathyroidism, they're more likely to develop stones. This is showing one of the treatment for the stones, which is the lithotripsy. In lithotripsy, the stones are pulverized by the focusing of the sonic shock waves on the actual kidney stones, and they break up in little pieces to allow them to pass. Many people are just told to let the stones spontaneously pass. Of course, they let them pass with a lot of pain medicine because it's very painful. Those small calculi, usually less than 3 millimeters, are treated just with observation and more fluid to just help the person to pass the stones naturally. The larger calculi, they're going to have some help, maybe even requiring surgery. There's a surgery called a basket extraction that's performed with the scope, where they insert a basket-like instrument to remove the stone. A patient may also have to have actual nephrotomy, where the kidney's cut into to remove the stone. Next, infectious cystitis and urethritis, inflammation of the bladder and inflammation of the urethra. Infectious identifies it as being caused by a pathogenic organism. The most common of the pathogenic organisms causing cystitis and urethritis would be E. coli, Klebsiella, Enterobacter, Proteus, and Pseudomonas. And certainly any of the sexually transmitted organisms are likely also to cause cystitis and urethritis. There's also viruses that can cause inflammation of the bladder and the urethra. A person can also develop this inflammation because of medications that they take or radiation therapy. Symptoms: urinary frequency, going very often, and urgency, dysuria, the difficulty or painful urination, and the patient may even have incontinence because of the inflammation. Diagnosis: usually just listening to the patient, talking about difficulty with urination, and then a urinalysis should be performed, the urine culture to identify the organism, culture and sensitivity to identify the organism and know which antibiotic is appropriate for treating the cystitis. So the organism-specific antibiotics. And I've listed 3 commonly used antibiotics when a person has any form of urinary tract infection. When I use the term urinary tract infection, it's abbreviated UTI. And anytime that a person has an infection anywhere in the urinary tract, it may be referred to as a UTI. Cystitis is a type of UTI, cystitis that's infectious. Urethritis is a UTI. The pyelonephritis I mentioned a few minutes ago is a UTI. And infectious UTIs, urinary tract infections, are usually treated with at least one of these antibiotics that I have listed on the screen, the Bactrim or the Macrodantin. Diabetic nephropathy, disease condition of the kidneys due to the diabetes mellitus. Because of long-standing diabetes mellitus, the person will develop renal changes called glomerulosclerosis. Signs and symptoms: urinary retention, hypertension. Hypertension again goes along with chronic kidney disease. Nausea, the protein in the urine. You see the same type signs and symptoms showing up over and over again when I describe the different types of chronic kidney disease. Urinary tract infections are very common in people who have diabetic nephropathy, the UTIs. Treatment is all about trying to control the diabetes, trying to control the hypertension, special diet. Dialysis may be necessary because it may very well progress to the end-stage renal disease. And then next is polycystic kidney disease. There's a great picture in your book, like this picture on the screen, of a kidney that has multiple cysts, both inside and on the outside. This is a hereditary disease, usually appears later in life. And these multiple fluid-filled cysts can be present and non-symptomatic, but eventually they're going to cause such damage to the kidneys that the person will have enlargement of the kidneys, nephromegaly. They'll have frequent urinary tract infections. Again, there's hypertension. And the uremia is a condition of having The uric acid, the urea, the nitrogenous waste, build up in the bloodstream because the kidneys are not filtering properly. Diagnosis made by the clinical picture, by the complaints that the person has, by the frequent UTIs. Renal function tests can be done, x-rays and intravenous pyelograms that will show that the patient actually has this enlargement of the kidneys with the multiple cyst. Again, it's hereditary. Treatment is very difficult. Treatment is more about treating the symptoms, keeping the blood pressure down, antibiotics for the urinary tract. Dialysis is eventually going to be needed, or a kidney transplant. Okay, the neurogenic bladder. The person has dysfunction of the urinary bladder because of a spinal cord injury. Neurogenic. The neurogenic bladder, the person may either have difficulty urinating, difficulty emptying the bladder, or on the other end of the scale, they may have problems with urinary incontinence, losing urine involuntarily. Again, caused by trauma or disease of the brain, the spinal cord, or those nerves supplying the lower urinary tract. Treatment is focused on, certainly if they can treat the neurogenic problem, but if they cannot treat that nervous system problem, then they're just going to try to prevent urinary tract infections and try to restore normal bladder function. Catheterization will be necessary, either intermittent catheterization or the patient may have to have an indwelling catheter. It's a good picture on page 541 under enrichment of the urinary catheterization process and the indwelling catheter in the female and the male. Stress incontinence. I think I talked about stress incontinence when I taught about the female reproductive system. Females are more likely to have the stress incontinence because of damage to their pelvic muscles during childbirth, weakening of the pelvic floor muscles. When the woman goes through menopause and has less estrogen produced, they're much more likely to have a weakening of those pelvic floor muscles. And in stress incontinence, when the patient coughs or sneezes or laughs, they'll have leakage of urine from the bladder. Stress incontinence, lack of voluntary control of urination. Treatment consists of exercise, estrogen replacement. Certain medications may help. Surgical repairs available in some cases. And then renal cell carcinoma. I've got a picture of a kidney here that is affected by renal cell carcinoma. The person has one or more malignant tumors that develop in one or both of the kidneys. It's also referred to as hypernephroma, and it is a cancer, it is a malignancy. Now, if a cancer or a malignant tumor develops in the kidney of a very young child, that cancer is referred to as a Wilms tumor. The Wilms tumor occurs in the very young patient. Otherwise, it's renal cell carcinoma that is primary cancer, which means it originates in the kidneys. Results in a hematuria, again, that might be microscopic. Over time, though, the patient may start seeing the actual hematuria, and then they definitely need to find out what's going on with the hematuria. Hopefully, hematuria, blood in the urine, will just be a sign of an infection that the person has, but it may be a sign of renal cell carcinoma. Oftentimes, metastasis has occurred before detection of the primary cancer, which means that the cancer may originate in the kidney, the renal cell carcinoma, but by the time it's diagnosed, it has spread to some other site in the body, metastasis. Cigarette smoking has been implicated as a major factor in development of kidney cancer. Early treatment's absolutely necessary before it spreads, and the treatment's going to be nephrectomy, removal of a kidney. A person can certainly have removal of one kidney. They can function with just one kidney. but they must have at least one kidney to function. Here's a picture of carcinoma of the bladder, which is the most common site of malignancy in the urinary system. A person could have just a tumor of the bladder that is benign, but the tumor may be cancerous, and it may metastasize before it's even identified as being present in the tumor. I'm sorry, I said present in the tumor. The cancer may spread before it's even found to be present in the bladder. Occurs more frequently in men, more frequently in people over the age of 50, and they have found association with certain occupations and the development of carcinoma of the bladder. And they've also found a strong association between cigarette smoking and the use of tobacco and carcinoma of the bladder. Signs and symptoms, again, the hematuria, dysuria, nocturia, which is having to go to the bathroom frequently while a person's sleeping. Cystoscopy with biopsy is the most common diagnostic procedure. The procedure may be used just to perform the biopsy. If the tumor is not too advanced, they may be able to remove the tumor with cystoscopy. They may even, because of a more invasive tumor, have to perform a cystectomy, which would be removal of the bladder. Chemotherapy is usually necessary also, and maybe even radiation therapy also. And this concludes the lecture on the diseases and conditions of the urinary system.